So a very good afternoon to all of you, and thank you, Uni, and the entire RIC team for giving me this opportunity. So, majority of the uveitic conditions are primarily a clinical diagnosis, and if supported by the basic imaging tools, I think we really don't need the high-end imaging systems. But yes, ultra-wide field imaging does add, and it gives a rapid, comprehensive evaluation both of the macula and the retinal periphery in one frame. And it also helps to serially document the findings. It also scores over the conventional imaging in poorly dilating pupils, which we very often have in our uveitic patients. So this is a case which is having the vasculitis primarily concentrated at the posterior pole, and this can be very beautifully picked up just with a conventional FFA, not really requiring an ultra-wide field imaging. But if you look at this image, and if we were to do a conventional imaging, everything appears quite normal, till finally we land up doing an ultra-wide field imaging, and we find that there is an element of active vasculitis in the retinal periphery, and we really do not need to stop the treatment, and the patient does require to be on an active treatment. This is a patient who is having an active retinochoroiditis patch, very much suggestive of toxoplasmosis. And if we do a conventional FFA, we do pick up this active patch which is present at the posterior pole. But when we do ultra-wide field imaging, what we find additional patch in the periphery and also an element of the Chiarese arthritis, which apparently we could have missed if we did stick to only a conventional imaging. This is a patient of tubercular multifocal choroiditis, and again, if you see the usual conventional imaging, 55 to 70 degrees, everything appears to be quite healed, and the patient seems to be doing well, till finally you pick up these active peripheral patches, which we would have missed if we would not have done ultra-wide field imaging. This is another patient. I think the RIC also showed this image where a patient of vasculitis, and you can get some excellent information regarding the retinal periphery, including the capillary non-perfusion areas, active neovascularization, and active vasculitis. And you can very well then do a targeted laser photocoagulation managing these types of patients. This is a patient of Behçet's disease with very poorly dilating pupils again, and if you do a conventional imaging, all that you can see is a disc leakage with some element of active vasculitis. But if you do a ultra-wide field imaging, you can very well see more information regarding the retinal periphery, and you do see active patches of focal choroiditis. And if you opt for ultra-wide field fundus fluorescein angiography, you can pick up much more information, thus telling us that there is an active recurrence of the disease in this particular patient. This is a patient presenting with vitritis in the right eye, and you really don't know why the vitritis is happening. You really cannot pick up the cause. But when you do ultra-wide field, you can pick up this active patch of toxoplasma right lying in the periphery, which otherwise could have got missed. This is again a paper published by Anirudh, where he has beautifully shown that you have patients of serpiginous choroiditis, and if it is concentrated in the peripapillary area and posterior pole, you can very well manage these patients. But what you can really miss upon is the occurrence of the paradoxical reaction, which sometimes can be very fulminant, right, lying in the retinal periphery. And the patient, you can really, have a mishap if you do not pick up the paradoxical occurrence very early on. This is a patient of primary vitreoretinal lymphoma and a typical RPE deposits, which you appreciate on the OCT. But when you do ultra-wide field autofluorescence, you can beautifully pick up these deposits, which you can see the far extent of all these deposits in the entire retina. This is a patient of sympathetic ophthalmia with extensive exudative retinal detachment, and on ICG you can beautifully appreciate the underlying extensive choroidal inflammation, which otherwise you probably may not pick up. This is a patient of intermediate uveitis, which kept coming back with recurrent vitreous hemorrhage, and on doing an ultra-wide field imaging, again you see an element of active neovascularization in the periphery. You treat it with laser photocoagulation, the active NVE regresses, but you do see a persistence of this peripheral capillary leakage, which probably you can really observe and not do any active intervention. So sometimes you can get this extra information which you have to really ignore and not really bother if it is not causing any impact on the visual acuity. So ultra-wide field imaging does score over conventional imaging, as it helps to see more of the retina through poorly dilating pupils in uveitic patients. You are able to assess the peripheral retina for pathology and reactivation of the disease and serially document the response to treatment. However, the limitation is that you can get excess information which may not be clinically relevant, such as the persistent peripheral vascular leakage that I just showed in my last case. I just want to acknowledge the contribution by Dr. Rima and Dr. Shishir, who did give me some of their patient images for this presentation. Thank you so much.
Thank you, Dr. Manisha.
Excellent cases, ma'am. I'd just like to add 3 case examples where I think ultra-wide field is very useful. One, I feel ICG ultra-wide field is very useful in patients of sarcoid and VKH, where you can see granulomas all the way to the periphery. Second scenario is when you have a patient of AN, you could look at the peripheral vitreous and you could actually see the vitreous detachments, and that could be a prediction for retinal detachments in these patients. Third situation where I recently found Optos to be very helpful was in patients with small pupil, pediatric patients with JIA, those who require surgeries such as oil removal or even a retinal detachment surgeries. The Optos actually gives you a clue that there could be a ciliary body membrane, a cyclitic membrane in the periphery. If you do steering photographs, you could probably have a glimpse of the fibrosis in the periphery. And if you don't have a UBM, you could actually look at the Optos and get a clue. And this could be very useful when you're planning surgery in these patients.
So I actually wanted to ask you a question, that there's a description in literature that you can pick up the vitreous fibrils much better on an ultra-wide field. Do you really practically put it in use?
Yeah, I think so. There is one manuscript also on by my friend Alessandro Marchesi, who's now in the US, where he published it looks like a cloud of vitritis in patients of lymphoma, and in patients of viral retinitis, I think, like I said, it is very useful to document.
Right.
The other uveitic condition, obviously, which is very useful with ultra-wide field ICG is birdshot choroidopathy, where you see those hyperfluorescent lesions, and often if you just focus in on the posterior pole, you might miss it. We've been sort of really highlighting the advantages of ultra-wide field imaging. One of the things I forgot to mention previously, particularly when we're talking about tumours, is we do have to be careful about the pseudo-colour, because often we can get misled, particularly with choroidal hemangiomas. They can look pigmented, and we can get, if you haven't looked in the eye, you can be misled as to what it actually looks like.
Can I ask you this? When you measure tumors on wide field imaging, does it give you an erroneous result, or do you fairly use it accurately?
I use it all the time. Obviously, it is, as was mentioned before, you're trying to measure a two-dimensional measurement on a curved plane. But what we're really interested in is changes over time. So I think it's still useful.
Thank you. Just one question to Dr. Manisha. You showed a slide of a peripheral vasculitic lesion in the capillary. How often do we see just a peripheral vascular leakage which doesn't amount to a vasculitic pattern?
Very
and
often.
how would you differentiate that, obviously with the rest of the clinical features, but based on just a wide field angiography, it seems to be quite difficult to...
I think very often we get to see these cases where we would be getting a cystoid macular edema. There will be no evidence of any active vasculitis on a conventional imaging. And we would keep wondering, because we find that we would assume that the disease is totally died out with the treatment, but when you do an ultra-wide field, you would find a very active vasculitis lying in the periphery. And probably that would be the reason why you would be having the patient having a CME or a decreased vision. So maybe I can ask Dr. Uni to give more than 5 minutes next time to include more cases. Thank you.
We'll give you a couple of more talks next time.